Thank you, Holly. It's a huge privilege to be here and to talk to you about the findings of our study. I would like to acknowledge that the collaborative team is a very large team. I've got a photo of us all at the end. The study was led by the National Perinatal Epidemiology Unit in Oxford, and as a collaborative study group, we involved midwives, obstetricians, health economists, epidemiologists, maternity service user organisations, and professional colleges, and I've probably left someone out, social scientists. So I wanted to start with a little bit of context for those of you that are not familiar with the context of this study. So in England, we have about 680,000 births. The majority of those women give birth in the public health system, our National Health Service. 40% of our births are attended by obstetricians, hospital doctors, and 60% by midwives. And I've just put the numbers there of the number of full-time midwives we have and the number of consultant obstetricians to give you an idea of the staffing skill mix that we have. And I put our current rates there because you'll then be able to contextualize the findings from birthplace within the national rates. So, where do women give birth in England? In 2010-11, the majority of women still give birth in an obstetric unit. 92% of women still give birth in an obstetric unit. I've put the numbers of units that we have there for you. 3% of women give birth at home. 2% of women give birth in a freestanding unit, what you would call a freestanding birth centre, that is geographically separate from the obstetric unit and where a woman would need transport in an ambulance to reach an obstetric unit. And 3% give birth in an alongside midwife unit, which is, I think, what you would call a hospital birth centre. So both those midwife units are led by midwives who have clinical accountability for the women in their care. But what you do need to understand is that we have an integrated maternity system in the UK where women can transfer from outside of an obstetric unit into an obstetric unit, and those midwives will come with her and transfer her. There are no barriers to transfer. So I think that's quite important for you to understand. Why did we do this study? Well, our current evidence is we like to be evidence-based in our current policy. And our current policy has said for about 20 years now that women should have a choice of where they choose to give birth, and that those choices should be informed by evidence. And we felt that the government felt that there was not enough quantification of the risk and benefits of women choosing to give birth in these different settings to enable them to make an informed decision, and also for decision makers. And interpreting that evidence has been difficult because the actual place of birth has been used to make inferences about planned place of birth, and it's absolutely crucial to be able to look at outcomes by planned place of birth and to follow women through and to use an intention to treat analysis. So the Birthplace in England research programme was commissioned by our Department of Health. It's had 2 streams of research funding. And the aim was to provide high quality evidence about the processes, outcomes and costs associated with different settings for birth in the English NHS, and also to understand the cost effectiveness of birth outcomes, but also women's experiences and how we organise and deliver services in these different settings. So it's a programme with 6 component studies. And I was co-leading the qualitative case studies on how care is organised and delivered. I'm only going to talk about the prospective cohort study, but all of these reports are available online, and now there are several papers as well, and I've put the references to those at the end of my presentation. So the primary objective of the cohort study was to compare intrapartum and early neonatal mortality and morbidity by planned place of birth at the start of care, face-to-face care in labour, in women judged to be low risk. Now, as I said earlier, we have national guidelines for women who are healthy, deemed to be low risk, and within those guidelines, we have a set of indicators where it is felt women would be advised that they would be better placed to choose to give birth in an obstetric unit. We don't use the word allow, we say women should be informed that these are the evidence-based guidelines based on a review of international evidence. We use those risk criteria to select our healthy women. Now, this is a rather complicated slide, and I'll talk you through it. So our sample was all NHS trusts, NHS care providers in England, providing intrapartum care at home, all freestanding midwife units, all alongside midwife units, and a stratified sample of obstetric units. So our total sample, our total eligible sample, was around 64,000 low-risk women, and women who had a single baby, they were term, they had received antenatal care, and they had planned to give birth in a birth setting, so unplanned births were excluded. I've just put down for you here the numbers in the final sample. We did a power calculation based on our composite perinatal outcome, and we needed to achieve 57,000 women. So we went well over that with our total sample. Our comparison group was planned place of birth at start of care in labour for low-risk women at home, freestanding units and alongside units and obstetric units. All our comparisons are with the obstetric unit, and this is not because we assumed obstetric units were safer, but because of the statistical power that that gave us to do the analysis in that way. And we adjusted for maternal age, ethnicity, socio-demographic characteristics. This is because the women who chose to give birth at home and in freestanding midwife units were older, whiter, better educated, and lived in less disadvantaged areas. So we had to adjust for these characteristics. So are there differences between planned birth settings and outcomes for the baby? This was our primary outcome. Now, one of the things we found was that there were complicating conditions at the start of care in labour. These were unexpected, but what we did find was that 20% of women who planned to give birth in the obstetric units had what we call complicating conditions, compared to about 77% in the other settings. Our planned analysis had not taken this into account. So how we have reported this in the BMJ paper is to report the planned analysis, and then we report on the restricted analysis of this low-risk sample. So we are comparing like with like across the 4 settings. And where there are differences, I will talk you through it. The kind of complicating conditions that I'm talking about are meconium state lichor, proteinuria, abnormal vaginal bleeding. We don't know why this happened. We think that it's probably because the system is working well and women were phoning their midwife and being advised to go to the obstetric unit. And the starting point for our study was face-to-face care in labour. But it's a hypothesis and we don't know, but it's important to adjust for it. So the adverse perinatal outcomes, out of this sample of 65,000 women, we had 250 adverse perinatal outcomes. It's a composite outcome because in this low-risk sample, we would never, ever have had enough power to just look at intrapartum stillbirth and early neonatal death. But what I've done here is to give you the percentages that fall into each category. We had 32 stillbirths and early neonatal deaths out of 65,000 women. So the event rate overall was 4.3 per 1,000 births, but that differed for nullips and primips, and it was higher for nulliparous women compared to the primips. And here I've put the adverse perinatal outcome by plan-based place of birth for all women. And in the whole sample, there were no significant differences between the settings. When we did a subgroup analysis by parity, we did find significant differences. So the odds of the primary outcome for nulliparous women who planned to give birth at home was 9.3 per 1,000, compared to 5.3 per 1,000 in the obstetric unit, and that's a significant difference. We found no significant differences for nullips who were planning to give birth in midwife units compared to the obstetric units, and we found no significant differences for multips who planned to give birth in any of these 4 settings. With the restricted sample, it strengthened the effect for the nullips who were planning to give birth at home, but it didn't have any impact on the other settings. This data is all in the paper if you want to have a look at it in more detail. So to summarize the perinatal outcomes for low-risk women, the incidence of those adverse perinatal outcomes is low. For multiparous women, there was no difference in perinatal outcome between any of their planned place of birth setting. And the incidence of adverse perinatal outcome for nullips was higher compared to the nullips who were planning to give birth in an obstetric unit. So these are our secondary outcomes. How does planned place of birth affect maternal interventions? And here we looked at mode of birth, maternal morbidity and mortality, and interventions during labor. One of our outcomes is an outcome we call a normal birth outcome. This is a definition derived from our information census statistics. And normal birth is defined as a woman who gives birth without induction, epidural, spinal analgesia, general anesthetic, forceps 1-2 C-section or episiotomy. And last year, 47% of women in the UK had what is defined as a normal birth. And here are maternal outcomes. This is for the whole sample. So the intrapartum, these are all low-risk women by planned place of birth, and the caesarean section rate for women planning to give birth in the obstetric unit was 11%, compared to between 2 and 4% for women planning to give birth in those other settings. There is a similar pattern for the other interventions, not quite so stark, and a reverse pattern for the normal birth rate. And women who were able to access water for pain relief in labor, the numbers were lower in the obstetric unit. One of the key concerns around birth settings is what happens to the women who transfer. So here are our transfers for the whole sample. So overall, about between 21 and 26% of women transferred during labor or shortly after birth. When we separate that out for nullips and multips, then a far higher percentage of nullips transfer, between 36 to 45%, compared to between 9 and 12% of multips. I've put the most common reasons for transfer down here. Failure to progress in the first and second stage were the most common reasons. Not all of these were what we call blue light transfers, and epidural request was part of that. We also had some qualitative studies looking at women's experience of transfer as well. The concerns around the transfer distance meant that many women did not feel they had a choice. a realistic choice about where they would plan to give birth, because they had concerns about the arrangements, the time, and the travel for transfer. But most women were prepared for the unpredictability of childbirth and were prepared for the possibility of transferring. Some of them felt they had not been prepared for that. Some women, as you would expect, found transfer worrying and disempowering, but they found that careful explanation by health professionals would facilitate that process for them. And having continuity of care helped that process and made it a much smoother journey. So here's the conclusion of the prospective study. For low-risk women, the incidence of perinatal outcomes was low. There were no differences for multips by planned place of birth, and that was in the whole sample and the restricted sample. The risk of an adverse perinatal outcome was higher for nullips planning to give birth at home, and that effect was strengthened in the restricted sample. And all low-risk women planning birth in the out-of-obstetric unit settings had lower intervention rates, but the intrapartum transfer rates were between 36 and 45%. I've got one slide on the economic analysis. It was very complicated. It's reported in the BMJ. We costed, it was a bottom-up costing of all resource use that were attributed to the planned place of birth. And basically, we found that there was a gradient for cost per birth from the obstetric unit through to home. If you want the details on that, the appendix in the paper is online. Implications for practice. Guidance should be updated for women to give them better and more accurate information on how they choose and where they choose to give birth. We think we need to improve the variation in our out-of-hours cover and our out-of-birth transport and referral and transfer guidance arrangements. There is variation there. There is concern by all our professional colleges and user groups about those higher rates of intervention in obstetric units in this very low-risk group of women. That we should be expanding that midwife unit provision, and I have to say that the popular choice seems to be the hospital birth centres, because in straitened economic circumstances, building a freestanding midwife unit is not a popular option, but we're reconfiguring our maternity services, so our small obstetric units are closing because of concerns about safety in small obstetric units. And we're beginning to get reconfigurations where a small obstetric unit will become a freestanding midwife unit within a network and a hub and spoke model to a larger tertiary centre. And we need to audit and review our intrapartum transfers. These are the issues birthplace can't address. The health economics are quite limited to a short time frame around the birth. We don't know why those women who are planning, nullips that were planning a home birth, had poor outcomes, poor adverse outcomes, and obviously it's an issue of concern. In terms of implications for future research, we would like to know what are the issues around clinical care and health systems and service delivery that are modifiable to improve the poorer intrapartum outcomes and the poorer perinatal outcomes. How can we improve the information that socially disadvantaged women have in terms of how they make choices about where they give birth so that we can improve equity in that? How can we better manage intrapartum transfer? And how do we make sure we have a really good network and system of dynamic ongoing assessment during the intrapartum period? And do models of care that provide continuity and cross settings improve safety for women? So I would like to thank our funders who have so generously funded this research. There's more information, the full reports, there's a short summary on the NPU website. And here is our collaborating group. This was taken at the start of the study, and some of us now have a bit of grey hair, but we're all talking to each other and doing ongoing studies together following up birthplace. So thank you.
Thank you, Jane. I happened to be doing research in London the year in the middle of that study, and it was just amazing the collective effort of all of the trusts in collecting those data. So our next speaker is Dr. Carol Cicala, who is the Director of Programs at Childbirth Connection, which works to improve the quality and value of maternity care through consumer engagement and health system transformation. She works across the continuum of clinical effectiveness activities, including primary data research, systematic reviews, performance measurement, clinical practice guidelines, and consumer decision aids. She was a Pew Health Policy Fellow at Boston University, where she received her doctorate. She's going to review for us the evidence that links what we do in caring for women during childbirth with health outcomes. Please welcome Dr. Cicala.